Okay, so it's just ticked over on 12 o'clock, so time to start off our inaugural new seminar series of Mind the Gap. Welcome everyone. If we can go to the next slide, please, Renee. So welcome everyone to the new quarterly RHIP innovation seminar series, which we've entitled Mind the Gap. Briefly, the aims of this series are really to in two parts. We want to be sharing information about innovation, useful aspects of how, things like people from the TGA, or we might get patent attorneys in, or talks from myself about innovation processes such as today. And then the other element is to have case studies from people like Miles is doing today around, how you actually turn some of these innovation into real life studies. The third element really is to build community interest. We want to build a network for the Randwick Health Innovation Precinct of people who are interested in innovation. So really keen to get your feedback. And this is a reach out to you as a community to try and start building that process. Some housekeeping issues. All of the mics are on mute, so if you want to ask questions, there'll be two question sessions, one at the end of my half of the talk, another one at the end of Miles's talk. So please use the Q&A button at the top to type in your question. And this is being recorded at the moment. We'll edit it up and we're going to post it on YouTube, so anyone who couldn't make it can watch it later. For feedback, there'll be a survey, a Teams survey coming around afterwards. Which we please encourage you to give us your thoughts and your feedback on how good this was, how useful it was. And finally, why do we call it Mind the Gap? Well, I suppose it's a catchy title. I'll let you be the judge of that. I suppose the meme of Mind the Gap comes from the London Underground. I spent 10 years living in London, and hearing that announcement every time I use the London Underground. But I guess the relevance here is a bit of a play on words, meaning the gap is a medical need which we want to fill through innovation. So using our minds to mind the gap. And I just want to say thank you to the team that helped organised this today, Renee, Matt and Ali, who helped put this mechanism together. Really grateful to them, and there's their email addresses at the bottom if you want to get in touch with any of us. Next slide, please, Renee. So, as I say, today's speakers, myself, I'm the Randwick Health Innovation Precinct Industry and Innovation Lead. I've been in this role for about 18 months. And today it's a great pleasure to welcome Dr. Miles Park. He's a senior lecturer in industrial design at the University of New South Wales. And I think he's got a really interesting story that exemplifies some of the issues I want to talk to today about the process of innovation. Next slide, please, Renee. Okay, so what I want to talk about today is how should RHIP drive health technology innovation, and at the end I just want to talk a little bit about commercialization, because this is a word that comes up a lot and can cause some controversy. So next slide, please, Renee. So first of all, I need to introduce the precinct, and on the left-hand side is the physical precinct. It's kind of an inverted L shape. It's the part in blue, by the way. So UNSW on the left. On the far right is the health campus with all the hospitals and some of the MRIs, and in between is the building site. Actually, this is a bit of an old photograph. It's advanced much more than that. So it's a very well-connected precinct in terms of its physical presence. But more importantly, I think from the innovation perspective is the collaboration opportunity. And the precinct was founded by 4 partners: South Eastern Sydney Local Health District, UNSW Sydney, the Sydney Children's Hospital Network, and New South Wales Government in the form of health infrastructure. They're the ones organising the investment in the building works, but they're also coordinating the activity from a New South Wales strategy perspective in what these precincts are all about and what they should deliver. In addition to those 4 founding partners, there are 14 medical research institutes, centres and other service providers that form part of the entire collaboration. So very large network. We're not the only state significant precinct within Sydney, as you would know. There's Randwick, there is Westmead, there is Camperdown, and there is Liverpool as well. They're with one of the 4 health and innovation precincts within Sydney. So why are New South Wales government developing a health precinct strategy? Well, it's really about contributing to the New South Wales government agenda. And from an innovation perspective, they speak about the importance of precincts in the Turning Ideas into Jobs action plan, call for the turbocharging of precincts in general, not just health precincts, to attract national and global technology industries and investment and drive collaboration between universities, research organisations, startups, scale-ups and SMEs to commercialise R&D. So the precincts play an important part in developing new ideas, new health technologies, implementing them at the precinct, but also in forming relationships with business and commercializing some of that health technology to create economic development for the state. Next slide, please, Renee. As well as the New South Wales precinct, there is also strategies from the precinct partners. There's one on the left here from CESLED. They are very keen on shaping the future around digitally enabled healthcare. SCHN, Sydney Children's Hospital Network Strategic Plan, talks about game-changing technologies in genomics, proteomics and big data, impacting our capacity to deliver precision medicine. And from a precinct level, there is also a strategy I encourage you to have a look at, which was 2021-2024 strategy, in which there are 3 main priorities, and the second priority, priority B, is about innovation and collaboration. And it says we will create an inclusive environment supporting our impact on the local and the global stage. So next slide, please, Renee. So those are the overarching strategic objectives, but when we think about it from a precinct perspective, and this is something I've been considering ever since I started this role for the last 18 months, is what can the precinct add? How can it value add to the precinct partnership and create something that couldn't have happened if the precinct hadn't been created? And in order to do that, we need to think about RHIP's differentiating features. And I've just listed some of them here. So from a footprint perspective, RHIP's located in a residential suburb that does not lend itself easily to co-locating manufacturing industries or multinational company headquarters, but it is ideal for startups and SMEs who need access to research infrastructure, and we're already doing some of that already. From an R&D capability point of view, UNSW is a top 50 global university with strong expertise in medicine, biotechnology and engineering. Also has an additional 14 MRI centres and institutes with discipline-focused R&D capabilities. From a talent pipeline point of view, UNSW generates high-quality students to be the thinking pairs of hands of innovation. Someone's actually got to do the work on this. From a collaboration point of view, UNSW, the hospitals and the MRIs are close geographically and strategically and have a mature and effective decision-making governance mechanism. From an industry co-location point of view, UNSW is currently home to 5 external co-locating biotech startups and SMEs, and UNSW is already generating quite a few startups from an internal point of view. It supports UNSW founders, supports staff and student spin-outs, and it runs the National Health 10X program, which is run in collaboration with the George Institute, and it's just started the SynBio 10X program as well with Main Sequence Ventures. So I think taking all that into account, the conclusion is that RHIP is best placed to work at the early stages of innovation, to be the creators of new health technologies, to work with startups and SMEs, small to medium enterprises, and create new biotechnology spin-outs. And that's a key element of the engine of health technology innovation for New South Wales. Next slide, please, Renee. So who are the team? The RHIP team, there's 8 of us all together. Some of us have only joined recently. Myself and Brooke have been here for the longest time, but we've only been in the role for, as I say, around about 18 months. So the executive director is Brooke Griffin, just been employed is our new appointee program manager, Brooke Selby. She'll be joining us very shortly. I'm the industry innovation lead. Matt is the communications and advocacy officer. Next slide, please, Renee. The other four are the translational research lead, Sam McFedries. Renee is the Precinct project officer, who you can see up in the top left as well. Sophie is the placemaking curator and producer, and Ali is the interprofessional education lead. Next slide, please, Renee. All right, so that's just a little introduction to the Precinct. What I want to talk about for the next 10 minutes or so is what does it take to turn ideas into inventions? I'm going to share with you three ideas or three concepts that I think are critical to innovation, the process of innovation. They're not my ideas, they're not new. I'm just conveying them, but I think they're my kind of top picks for important elements of health technology innovation. And the first one is in brief, is it's not about the idea, it's about building networks. So this is a viewpoint that is well represented by a character I'll introduce you to in a moment, who talks about the process of innovation being critical, forming of teams, forming of networks, not about the idea. Okay, so I'm going to communicate this through a story of the invention of penicillin, which I contend here that it's the best invention in the history of medicine. I don't know whether you'd agree with me, but certainly a very important invention. And I think we all know the story of how it was discovered, but I think it's critical to understand this, where exactly the innovation took place. So Alexander Fleming, the story is that Alexander Fleming came home from some time away and found that there was mold growing on one of his bacterial dishes plates, and he found that there was a halo of bacterial cell death around the mold, and realized that obviously the mold was producing some antibacterial factors. So he investigated that and discovered that the mold that he had in his dish was Penicillium genus. He also noted that it wasn't the mold, but some sort of juice that the mold produced. And he also tested out that mold juice on a variety of different bacterial species and found that it was quite effective as an antibacterial agent. But it was very difficult to isolate the mold juice, and the paper that he eventually published in 1929 was published to almost universal indifference, and nothing happened for virtually the next 10 years. Next slide, please, Renee. And it really wasn't until a team that was assembled by Howard Florey and Ernst Chain, a group of biochemists and chemists and biologists who were brought together at the University of Oxford to start looking at different antibacterial agents. They were not only looking at the mold juice, they were also looking at the contents of tears, for example, and trying to identify some of these and isolate the compounds involved. And it took them absolutely ages, a real hard-working team effort to purify it, to stabilize it, to eventually put it into a formulation that you could deliver to people. And they had to do the preclinical testing and the clinical trials, and all of that work is really the work of a huge team that was organized by Howard Florey and Ernst Chain. And the first use of purified penicillin wasn't until 1942, and as a consequence, Fleming, Florey and Chain were all awarded the Nobel Prize in Physiology or Medicine in 1945. So this is the point, that the innovation process was really about the capability to build a network, to build a team. It was not about the originating idea, because the idea was kind of mouldering on the if you'll excuse the pun, on the shelf, until Howard Florey and his team really pushed that through to form a new form of medication. Okay, next slide, please, Renee. The next concept is about identifying a well-defined need. And this is critical in the process of innovation, and the innovation should come from a need, not from a technology. And this is well demonstrated through the biodesign program, which has now been running at Stanford University for the last 20 years. And this came out of an observation that through some employees at Pfizer, when they were looking at startup companies when they form around health technologies, and they noticed that companies would often hit the world stage with a really groundbreaking new health technology that was absolutely fantastic, and they would, be very successful. But the next set of inventions that they would come up would quite often be quite incremental and not as groundbreaking as the original idea that formed the company in the first place. And this is because what happens in that eventuality, in that situation, is that where these companies are formed, they become biased by their own technology. So when they, when they're thinking about what are we going to move on to next, they go, well, we've created this really cool technology. How do we apply it in other circumstances? They don't go back to the original process that led them to that breakthrough in the first place. They just they're biased by their own technology. So the creators of the biodesign program realized this, and they've now set up a program in which you systematically try and remove any bias of the technology you've already created, and you come back to focusing on the needs, and you really define the need very well. So first of all, you select a need, and then you really hammer it, and you say, well, what does it need to look like? What does is the patient going to take it at home, or are they going to take it in a hospital? Does it need to be portable if it's a device? How big does it need to be? How much does it need to cost? And you really identify the need without thinking about any of the technology at this stage. And it's only when you've really defined that need very, very carefully do you then go to not just one type of technology. You think of everything, every single technology that you could possibly put around an invention. And you list them all, and then you carefully compare them against the need that you have set, the well-defined need that you have set, and you say, is this meeting this the original need goals that we set in the first place? And if it doesn't, you discard it. And it's only after you've been through that process that you select the best one. Do you then start saying, well, these are the team members that we need. This is the type of expertise that we need. This is the commercial business plan. This is how we're going to raise money, etc., etc. So it's a very deliberate program that is based very much around the importance of the need in the process. So that's my second idea. Third idea, next slide please, Renee, is about milestones and deliverables. And this is called the Health Tech Innovation Cycle. It's created by the Consortium for Improving Medicine with Innovation and Technology, or the CIMMIT organization in Boston, Massachusetts. This was a collaboration that was formed through MIT and a couple of the hospitals there. It's now grown to 13 members of partners within Boston, including Harvard University, etc. So very successful organization, and probably the leader in the field in terms of a precinct organization and what can be achieved at a precinct level. And they've taken and they've created this model called the Guidance and Impact Tracking System, which really systematizes the process of the way a technology should develop and sets very strict guidelines on the deliverables that you should achieve at each particular stage. So, for example, at the ideas stage, you need to test those ideas with 5 clinicians, or, there's for the need identification, have you at this stage got a preliminary plan for the regulatory process? Is this what category medical device is this going to be, for example? And each of those deliverables need to be met in order to advance to the next stage. And this avoids a common mistake that happens in innovation, which is called the technology push. And the orange bar on the right, you can see that people get overexcited by the technology and they advance the technology way beyond the point where there is simultaneous development of the analysis of the regulatory or the competitor analysis of, or the clinical need. Are clinicians actually going to use this technology? Not asking those fundamental questions can lead to a mistake, and a technology can develop way beyond the point where it's not actually addressing a need anymore. It's, you're just getting overexcited by the technology. So this is a systematic process, and this is my fourth, the idea of having carefully synchronized progression through those stages with the different 4 domains of technology development, regulatory process analysis, the marketing and business strategy, and the clinical need. Next slide, please, Renee. So coming back now to our how we are planning the RHIP Innovation and Commercialization Program, we've been considering a model of where we are best placed as a precinct to try and impact and create something new that wasn't there before. And there are some fundamental questions here that we need to address in order to think about how that might work. So the first question is implementing innovation programs a role that precincts are suited to play? And I think the CIMMIT example I've given is a very good example where that has worked very well in Boston. So I think yes, the answer to that is yes. A second question is, at what maturity level could an RHIP program have the most impact? And I think it's early. And I think it comes back to those fundamental innovation questions we've just been talking about, that it's very important that you set things up appropriately and well right from the start. You're thinking about the needs, you're thinking about the team building, you're thinking about that progression through those domains, and assisting in that process is the best role that the precinct can play. And then how can an RHIP program support the development of all of those 4 domains: technology, regulatory, marketing and business, and clinical? Good program design, I think, is the answer, taking into consideration those 3 concepts that I've outlined today. So this is our plan as far as the precinct is concerned, and the model that we're working on at the moment to address the first 3 elements of the health technology innovation cycle, with an exit into follow-on funding opportunities. So creation of a prototype or creation of some good proof of concept data will be the exit from this program into follow-on funding opportunities, and hopefully you'll be really well set up to, if it's going to be a spin out, obtain funding from venture capital, or if you don't want to spin out, you want to kind of collaborate with a company and do an ARC linkage grant or something, collaborative grants, or you could enter into the UNSW Health 10X program or get from Cicada Innovation support. And then at some stage, that IP will need to take a commercial track, and there will be a technology transfer either into the spin out you've created or in partnership with an industry partner to actually take it that later stage through to the market. And I want to just focus on that in the last couple of minutes. Next slide, please, Renee. Commercialization, this word comes up a lot and causes some controversy. So, and I don't really have time to go into this a huge amount of detail today, but I just wanted to make a few remarks on what do we mean by commercialization and some considerations around it. So in brief, it's the process of bringing new products or services to market. Another way of thinking about it is that research is the conversion of money into knowledge, whereas commercialization is the conversion of knowledge back into money. And from a realistic point of view, particularly in medicines, pharma companies are the only institutions that can afford the major costs of registration or clinical trials, large-scale manufacturing, and global distribution. Public-private partnerships in health technology development are complex, and I'm the first to admit that, but the needs and objectives may differ, but often the outcomes and benefits will align quite well. If a health technology is going to be effective at improving the lives of patients and clinicians, it will probably also be largely commercially successful as well, and commercial organizations are very aware of that. The other point I'd make is that over the last 30 years, multinational health technology companies have reduced their reliance on in-house discovery science for new products. A 27 report on J&J and Pfizer's product list showed that 81% originated from third parties and accounted for 89% and 86% of their current revenue. So large pharma are very aware of the important symbiotic relationship they need to set up with organizations such as us or other health innovation providers around the world, and we need them equally to take those products to market once they've reached a certain level of maturity. The last point I would make is that from an Australia and statewide point of view, medical products are one of the 6 national manufacturing priorities of the federal government's University Research Action Plan. And the statement in that action plan is that increasing research commercialization is critical for our national interest. So you'll be aware that there's quite a big push at the moment to improve Australia's track record on commercialization, and medical products are one of those 6 national manufacturing priorities. So on my last slide, next slide please, Renee. The thought I would like to leave you with is that there's a lot of conversation at the moment on, there is this commonly held belief that that Australia is very good at creating research and, you know, ranks in the top 10 in the world in terms of its research agenda, but it's down in kind of the 40th category in terms of its ability to commercialize. And that's all true. And there are lots of initiatives and things trying to change that perspective. But from an RHIP perspective, I think the key really is to leverage what we have at the precinct. It's very important that we begin to collaborate and work together. That is the opportunity. That is the new opportunity we have. So my appeal to you is to get involved, become a collaborating partner, get involved in innovation, and reach out, and let's start forming some structures which can really pull some new health technologies that are going to improve the lives of patients and clinicians. And with that, next slide, please, Renee. I will offer it up for some questions.
Just a reminder, if you have a question, to pop it in the Q&A box, and it will get published for Steve to see. Things come through yet?
I saw somebody's hand go up.
Yeah, I've got a question come through. Here we go.
We're still testing out this technology.
I've just published one there. Thank you.
Okay. Oh, there we go. What practical support does the precinct intend to provide for health technology innovation? Yeah, great question. So as I say, we've been at this for kind of 18 months. With most of the process that has been happening so far is that stock taking, understanding of what the precinct can provide, and then trying to assemble a model that everyone can get behind. And that model has advanced its way through the governance cycle and has been approved by RHIP, the RHIP governance mechanism. So the next stage is to say, now that we all agree that this model is the one we want to chase, the next stage is to try and get some funding behind it. And at the moment, we are pursuing several different avenues for funding, and we really hope to have an answer on that, you know, reasonably soon. But once we have an understanding of, you know, what scale of budget we have to play with, then we'll make some announcements about, you know, how the program will be rolled out and what sort of specific practical benefits we can provide. Okay. If there's no further questions, we might make a start on Miles's talk, please. Can you go to the next slide, please, Renee? There we go. Over to you, Miles.
Thank you, and hopefully you can hear me all okay. Well, this is a rather modest project in terms of the ambitions, I suppose, for the group. However, I believe it's a good example of a collaboration which delivered a product into the hospital, which is now being used at Prince of Wales. So I guess it's a bottom-up innovation in the sense that it's driven by a relationship that was first established through the hospital, which is adjacent to University of New South Wales, and it's about addressing a need, a clinical need, a use or market pull in terms of framing the project. So, as Stephen suggested, a lot of these projects are about technology push. This is very much about them coming to us and saying, well, here we have a clear need, can you help us out and solve our problem? And what it is, it's called an ICU ventilator equipment trolley, or as they refer to it as the ICU tower. And essentially it's an ICU unit on wheels. So it brings together vital life support equipment, such as a ventilator, IV lines, syringe pumps and drivers, patient monitoring equipment, oxygen, backup cylinders, power and gas management systems, all into one unified, mobile and reconfigurable package. And so this offers a lot of benefits. And indeed, we didn't actually invent this as a proposition. It was something that they had already been using in the hospital, but the equipment they had put together was well over 20 years old, and a whole new generation of medical devices had come into the hospital, which made this original trolley system quite clunky and not very efficient for their workflow. So the benefit of the solution by unifying all these elements together is that it offers life support, patient care and monitoring equipment, which remains connected to the patient during transport from the ICU to different parts of the hospital, such as imaging and other specialist units. And so by remaining connected to the patient, it mitigates the risk of errors with disconnects and reconnects of various patient lines. There's benefits in terms of infection control, and Prince of Wales have developed this system into their workflow, which offers benefits for the clinicians and efficiency for their way they operate their ICU. Next slide, please. Thanks, Renee. So just a bit about the structure. It's a fairly informal and flexible project that essentially evolved in the sense that we started off as a student project, an undergraduate student project for industrial design students at University of New South Wales. And it emerged over time where it became a graduate project, and then it became the push for production of the preferred design for delivery to the hospital. So I'll take you through those stages of that design process. Funding was fairly independent. The hospital had secured their own funding for new equipment and some of the costs to be covered in terms of the production of this new ICU tower, as well as UNSW. I was successful, or I should say partially successful, in a new New South Wales Treasury Innovation Districts grant. We didn't get all the money we wished for, but we did get some seed funding, which sort of at least gave us a bit of support to get this project formalised in later stages. So it started pre-COVID in 2019, but curiously, COVID actually was the opportunity where the hospital acquired new ventilators and equipment, as well as this New South Wales Treasury grant system became a COVID-related grant system, which I guess that we sort of piggybacked onto in terms of how the project evolved over 2019 to 2022. Next slide, please, Renee. So in terms of the methodology, or perhaps more accurately, the process of the project, it was very much a design process. And I've just tried to illustrate it here in a very simplified form in terms of its linear staging as it runs through from the initial discovery of understanding what you're trying to solve and what the opportunities are with the project, right through to the production and building of the actual design for use. And what we know from this is that it often isn't linear. It's often a little bit more tangled and complex than that. However, this is a simplified way of representing that process. But it's a good, useful model because it gives you a way of structuring a project in clear progressions and ways to move towards your optimum outcome. And so, to paraphrase John Heskett about design, who is a UK academic who's written extensively about the history of industrial design, he says, "Beyond the confusion of froth and bubble of advertising, publicity and virtuoso designers and design gurus, design is to design a design to produce a design." So there's a lot of ambiguity when we talk about design. And a useful way that we try and frame design within industrial design circles is we think of it as a process. Indeed, it's a structured linear process as I've presented here in its simplest form, and a way to stage the project. Next slide. please. So just taking you through with some images and a little bit of detail about this process in terms of how it applied to the project. It starts with discovery. And so that's in the first instance, it was student visits to hospital, again, pre-COVID. This has become a little bit more challenging in recent times. And seeing how the clinicians and various people within ICU go about their role, and indeed understanding how the equipment is connected to the patient and how it's connected to the bed, and then how we move the trolleys around the hospital. So we drag them down the corridors into lifts. And so we get to understand a picture of what's going on. It's a bit like being a fly on the wall, to give you a bit of insight and understand essentially what the opportunities are in terms of the environment, the use, the behaviour and attitudes of various people towards the way they're doing things and with this existing equipment. So we got to understand how the existing equipment was worked and the opportunities that we were looking for of how that could go further. Next slide, please. The next stage of the process is that often we start sketching and developing initial concepts. And the idea here is to produce ideas quickly and often. So we're not investing huge amounts of time and effort into things. The idea is just to, and the reason we use sketching is because it's quick and instantaneous, and it's a nice way to communicate within the team. And if we move to the next slide, please. We also use a lot of sketch modelling, where we produce low fidelity prototypes. And the beauty about this sort of prototyping is that it's low cost and it's quick. And so that means that when you build something, it's not precious. It allows other options to be explored. It allows you to go off down dead ends and try things that are a little bit speculative, high risk, and then pull back and then try a different direction. And I've put some images up here of other companies that use this process, and we might think, well, you know, making cardboard models or trolleys that have got foam boxes on them sounds a bit student project, but this is a process that's embedded within companies like Dyson, and in of course, even in Sydney, in New South Wales, Sydney, I should say, we have Breville, who often use this low fidelity prototyping, which is embedded in their design process. And by doing so, it allows you to simulate how the product might operate. You can do some user testing. Often it's a co-design process where you might involve your users and get them to contribute. So they might come up with some new ideas. So you get the sticky tape out, you rip off one bit of your model and stick it on the other side, and then try that. See how that might be used in a simulated situation of use. You can also test some basic ergonomics about the function of the product. Could be to do with reach or the weight of things. You can actually put dummy weights in objects to try and simulate what those loads might be. And so incrementally, fidelity prototyping, you start to move closely towards a more optimum outcome. It's often analog, as I've said, and it's often pre-engineering. So we're not diving into CAD and computers. We're very much in this sketch modeling or sketching mode. Next slide, please. As we move through it, incrementally, we're moving to higher levels of fidelity with our model making. So on the left there, we can see we've moved from the cardboard models and cannibalized trolleys to building our own trolley. This was built in our own fabrication lab at the university, and this is built with steel, painted white because we're trying to just tidy up all the messy worlds and joins. And that's ways we can start loading real equipment on the trolley and get a high level of resolution in terms of what might go where. Next slide, please. As we become more confident with the design, and again, this is a relationship where we're taking the prototypes up to the hospital, leaving it with them for a few days, having a meeting with them, various people are throwing in ideas and can we change this? Can we do that? Or what if we did this? What if we did that? Once we get to a fairly tight understanding of what we can do, we then built a fully functional prototype, and this was undertaken primarily by one of our graduate students. If we can just go to the next slide, please. Who undertook this project. Nicholas took this for his graduation project, where we built a fully functional prototype in stainless steel. So we could then load this with all the equipment they intended to house on the tower, and we could learn a lot from this. So we could understand things that indeed for the next, this was the first final prototype, I should say the first design prototype, where we learnt about stability and frame rigidity. We learnt about the correct or the optimum placement of equipment. We understood things like turning geometry. So we got 4 caster wheels, and what we discovered very quickly was the shopping trolley syndrome, where this thing sort of wanted to wander off on its own. So then we had to sort of rethink that through. It gave us understanding about what if there were spills and drips on the top, where would they go? Could we make that fall clear of equipment so it wasn't dripping onto equipment? Ergonomic refinements. Nicholas and myself, we're certain height, but of course a lot of clinicians come in all heights and sizes. So we needed to understand about the whole a variety of different users that needed to access this equipment. And if we go to the next slide, please. So it's a journey of refinement. Here we've got various people at the hospital coming in and throwing in their ideas. Can we move the monitor here? What if we move that there? I can't reach around here, and so forth. So it goes through this journey of refinement. And here we're looking at a second stainless steel prototype. And so we've built about 4 prototypes so far, 2 very low cost ones, and these 2 which essentially are built in-house at, again, fairly low cost, but we're keeping the costs down because still lots of things can change. Next slide, please. As we get pretty close to our final design, it means that our design changes become more incremental, and so the risk is we need to have low risk changes because every change implies a higher cost, because we're starting to get to the level where we're working with difficult materials, stainless steel, welding, and putting this thing together. Next slide, please. Once we're happy with a design, we're essentially we're fairly confident we're close to an optimum outcome. Design documentation is produced in CAD. This is then put out for tender, and we can embed all the prior learnings from our previous prototypes. So we feel fairly confident we've got a fairly defined project or design. However, there are always things that can be changed. If you go to the next slide, even at this late stage where we build the first production prototype, we have to go through 8 revisions till we get our optimum design. And this is where any change starts to get expensive, and so you have to be very confident that those changes are worthwhile and they're the correct ones to make, and fairly limited in terms of their ambition. Next slide, please. So just to put all that together in terms of what the design means, is that we could say that some benefits of this are that it was an informal and evolving collaboration. I had no idea this was going to run for 3 years. It was very rewarding because we had a responsive and collegial team. Everyone was committed to this. I was immensely impressed with the ICU team and how they really want this to be an optimum solution for them. They really put a lot of effort into it, and they were very responsive and collegial in terms of how we work together. And now I think that's a really important part of any project success is you got to like the people you're working with, and everyone has to be seen to be as important and a part of the whole solution. We had mutual interests. They wanted a great product that was going to solve a number of their workflow and efficiency issues within ICU. I had mutual interests because this was a great student project for my guys to work on, as well as we could use for a graduate project. And then I saw some research opportunities that could spin out of this in terms of some funding and other projects that I could explore in this space. Location, that was a great benefit to us. We had the adjacent Prince of Wales Hospital to the university. That has a lot of benefits rather than having to travel halfway across Sydney to visit Westmead or elsewhere, which is, challenging. COVID, of course, threw up a lot of obstacles, but equally it threw up a lot of opportunities. Indeed, new funding opportunities came forward, and that was what the hospital and ourselves took advantage of. Some of the negatives of it was project drift, and we can see that with those previous slides, how we had 8 final versions or revisions of the final documentations because people kept adding little bits of, what if we have this or could we have that? So you end up with feature creep or project drift. So it's really important to manage those, and you want to have all that early in the project rather than happening at that final stage where you're at production. Subcontractors, everything's working very efficiently and very well. We put it out for tender, we get the quotes, we say, let's go with that, push the go button, and then they drag the chain. They have management changes, personnel changes, the main people we're dealing with leave, someone else comes on board, they need to come up to speed with the project. Promises are made, promises are broken. So contractors can be really difficult unless you are onto it all the time. And as this was a peripheral role to my normal responsibilities within my role at UNSW, you really need a project manager to drive this. And this is where perhaps the hospital could have taken much more action in terms of ensuring they were going to get their production in process as promised. So that was a bit of a problem. And the other thing is COVID, of course. Some of our meetings, we ended up having them down in corridors, down in the dock area in the hospital because we weren't allowed up into ICU. So we're having these informal meetings while there's trolleys of linen and other things travelling back and forth, and we're trying to have an informed, intense meeting about resolving some detail with our design. So that obviously is a challenge for us, and I'm sure everyone else has experienced that in terms of the way they've gone around their projects and daily business. And just to the right there, there's an image there showing the final, this is the pre-production prototype, all hooked up to one of the new beds that they are now using in ICU, just to give you a bit of context there. I wish I had a better photo to finish on, but that's the last one I've managed to take whilst all the equipment was hooked up. So thank you very much. I'll hand you back to Stephen.
Thanks very much, Miles. That was great. Fantastic. So once again, please do type your questions into the Q&A button, which you'll find at the top. And we'll, so any questions for Miles, or if you have any more for me, then that's great. But I might just take the chair's opportunity to ask Miles a few questions verbally since my mic switched on. So I was really interested in that last part when you were talking about that kind of, I can't remember what you call it now, invention creep or mission creep or something. You know, I recognise that from my days working for a biotech company, where you have kind of 2 arms of the company. One is kind of in research and development, and there's new things cropping up all the time that are kind of potential incremental improvements. And then you have the clinical development program where, you know, they're advancing a particular prototype either through preclinical stages or onto clinical stages, and to change it at that level would cause a huge amount of additional expense. So at what point do you say, you know, this is now good enough, you know, any incremental is probably our, you know, we've hit the point of diminishing returns, and, you know, we're going to go with this. And even if there are some improvements later on, it's going to be too expensive to change from that point onwards, if you know what I mean.
Yeah, I think a clever designer is often thinking about open-ended opportunities with the solution. So with this, we tried to create enough space on the mount rails to allow equipment changes and reconfigurations. So there could be some flexibility built into the design. But it's inevitable that always something pops up later. You know, can we have this, or this has now changed, we have to do it this way. So I guess the response would be is to try and get as much out of those early prototypes and those early discussions that you have by showing these prototype designs with the whole cross section of different people that will be stakeholders in the project, to give them an opportunity, and so you don't end up with any, well, hopefully you minimize unintended consequences or oversight. And then you do reach a stage where you just have to resist adding another feature. And sometimes the feature creep thing, you know, the new shiny thing might seem the great thing today, but then when everyone gets to reflect and think about it, perhaps in a week or two's time, they think, well, perhaps that wasn't really necessary. It just seemed great at the time. Yeah, it's a challenging one.
Great point. And I suppose following on from that, I mean, in the drug development game, you know, one of the phrases that's bandied about is fail fast, fail cheap, meaning that, you know, it's very important at the early stages to de-risk, you know, using whatever available means you have. If you have kind of in vitro methods of testing for toxicity or whatever, you know, which is the equivalent of your kind of cardboard models, and, you know, using these very inexpensive methods to try and de-risk it before you get to the stage where you're actually using expensive materials and lots of, you know, etc. So it's really interesting. There's so many parallels there between pharmaceutical development and between a product that you're trying to create through industrial design.
Yes, there's often that mantra, isn't there, in the startup community about fail often, fail early.
Yeah,
which is very important. Yes.
Yeah, great. Any questions coming through from anyone on the floor?
There's one in there from your presentation earlier, Steve.
Oh yes.
But
yeah.
no other questions so far.
Yeah. How does what your Precinct is trying to do align with other organisations such as Sphere? Yeah, that's a great point. I mean, we're working very closely with the organisers of Sphere and with iHealthE and with UNSW founders. We talk to Cicada Innovations, and we're very cognizant of the fact that whatever we do at the Precinct level does not duplicate anything that already exists. We don't want to be reinventing the wheel. We want to add value. We don't want to compete with existing mechanisms. So, you know, I think what's slightly different is from, let's say, what Sphere are doing, is that we have a place-based approach. What we're trying to do at Randwick is create or concentrate or crystallize innovation activity that is occurring at the Randwick geographical site, as it were, and for all of its partners. And so that is the objective, and that fits in with the New South Wales government's state objective of what they want out of these precincts as well. Whereas Sphere has a slightly different objective and different organisation. It's very, very aligned, but it's just slightly different in that respect. But I think the short answer is we are working very closely to ensure that there's no duplication or overlap. Any further questions anyone would like to post? No? Okay, well, with that, we've actually finished a little bit early on time. This has been a startup for us as much as creating startups. So we're innovating as well, and we've learned an awful lot from using the technology. I think we'll try and streamline things a little better for next time around. But is there one more slide just to say thank you, Renee? Thanks very much. Yes, there is indeed. So look, thank you very much for attending this first sessions. Please let us know your feedback. Really appreciate it. we intend this to be a quarterly series, again with a similar mix of information sharing and with case studies. Thank you so much to Miles today. That was a fantastic presentation, really exemplified some of the key principles, I think, of health technology innovation. So look forward to seeing you next time, and thanks everyone.
Steve, can I just say, sorry, we might have another question coming through. We just had maybe some issues with Q&A.
Yep.
Tim, did you have a question? If I allow you to pop on your mic, you can ask it verbally rather than through Q&A.
Thank you for that privilege, Renee. Sorry, I was trying to work out the technology, so apologies for that, and thank you for letting me ask a question. Look, I wanted to just say before, I think it's really interesting to listen to both of you talk, Miles and Stephen. It's a complete mindset change from development in the past, where a lot of discoveries were based on science and technology, like the microscope being developed, the electron microscope, subsequently confocal microscope, and discoveries around that. And that was all based around the technology being first and then the discoveries coming. This is a completely different story, where we're looking at having the problems driving the discovery. So I'm just wondering, maybe it's a time for maybe the engineers and the industrial designers. It's the time for them to take charge of development for discovery. It's really interesting. Really interesting development. I guess I'll stop there because I know you've finished. So thank you for the opportunity.
No, we've still got 2-3 minutes, Tim. So I'd quite like to invite Miles to respond to that as well. But I think that's a great point, Tim. I think I didn't mean to say in my talking about the importance of the way in which innovation occurs, that technology developments were in some way bad or weren't influential in the way we did research. I think it's critical. And it can be game changing. I can remember when PCR began. I'm that old, so, and PCR kind of revolutionized the way research took place from a molecular genetics point of view. It just transformed it completely, or, the way in which DNA sequencing occurred. And I think technology is often the driver of research. So, that's critical. But I think the point I was trying to make, and I think the point you're making as well, is that from a solving, there's a danger that we fall in love with the technology, and get blinded by that when we're considering the needs. And that's when I think things need to be turned around. Miles, would you like to comment on that as well?
Yeah, well, I think it would probably be dangerous if you just left industrial designers and engineers to solve the medical requirements for the future. But perhaps the way forward, and this is probably proven and by many case studies, is that it's about collaboration, cross-disciplinary teams working together, because medical innovations are often very focused in very specialist fields, and then I guess then you need to bring in other people to collaborate on that from different fields, whether it's engineering, business, industrial design, right through to occupational health, safety, and business and management practices. So it's just finding the right balance and combination to get all those things to work together. And I guess that's things that challenges any project manager, is to how to unify those elements so you get optimum outcomes.
Thank you.
So it looks like there's another question come through from Alison. Is there a patenting component to this? If so, how does this work with collaborative design with these partners? Is that a question for Miles, around whether you patent your design there, Miles, or is that more in general? Sorry, anyway, I'll let you answer that, and then I might try and make some comments myself.
Sure. Well, look, just quickly, I was actually anticipating a question about patents, because that's something that always comes up in the conversation about this. In this case, with the project that I'm working on, it's a fairly modest project. We don't believe there's any sort of innovative patentable features within the design. Yeah, and indeed the opportunities in terms of the opportunity cost of patenting is probably minimal, because we're looking at a single hospital application in this case. There's opportunities to scale further in the future, and that was something we wanted to explore with the grant that we didn't get. And that's where that comes into it. But the university has a fairly open approach to patents, and that is one for the experts that I can't answer. But over to you, Stephen.
Yeah, sure. Well, I've spent 2 years before I started this job. I spent 2 years working in the tech transfer office for UNSW, so I'm kind of familiar with the patenting environment. If that was the nature of your question, Alison, was that absolutely yes, that as these technologies evolve and form, there comes an ideal time where the invention protection mechanism should kick in, but there is an ideal time for that, and we have to be a little bit careful that often that's driven by the desire to publish, for example. But you know, from a technology innovation perspective, the judgment of when to begin the patenting process is pretty critical, and that needs to be done in close consultation with the tech transfer office, or people who really understand that process. So absolutely very important part of the process. Okay, perfect. We've hit time, so apologies for rushing the questions a little bit and not allowing those questions to come through. So I will continue with the saying goodbye. And again, once again, thanks everyone for contributing. Thanks to Miles for that wonderful talk, and look forward to seeing you next time.
Thank you. Thanks everyone. Bye-bye.
Bye.